If your doctor just told you your total cholesterol is normal and you're over 65, you need to hear this. Because after 30 years in emergency medicine, I've seen people with perfect cholesterol arrive in the emergency room with major heart attacks. And I've seen people with cholesterol numbers that would make headlines live into their 90s without one. The number I'm talking about isn't your total cholesterol. In many cases, it isn't even your LDL cholesterol. It's a different number entirely, a number that often predicts risk more accurately, especially after age 60 when the rules begin to change. Now, why hasn't anyone told you this? Not because it's a secret, not because your doctor is hiding anything. The reality is much simpler. Modern medicine is busy, appointments are short, complex risk factors get reduced to simple checkboxes, and sometimes the most important details get lost. After treating more than 10,000 seniors, I've seen this pattern again and again. Today I'm going to show you the cholesterol number that many heart specialists pay close attention to, why it matters after 60, and what you can actually do about it. I'm Dr. Richard Hartman. I'm a 62-year-old emergency medicine physician. I've spent more than 3 decades treating medical emergencies, and a large percentage of those patients were adults over 60. After seeing thousands of heart attacks, strokes, blocked arteries, and cardiac emergencies, one thing became clear. The people who ended up in the emergency room weren't always the people with the highest total cholesterol. There was often a deeper pattern hiding underneath. Patterns that weren't immediately obvious from a quick glance at their lab work. Patterns that required looking at multiple numbers together, understanding how they interact, and recognizing what they reveal about what's happening inside the arteries at a cellular level. In this video, I'm going to show you 3 things. First, why traditional cholesterol numbers sometimes miss risk after age 60. Second, the cholesterol-related number that often provides a clearer picture of heart attack risk. And third, the practical steps you can discuss with your doctor to improve that number and protect your heart. Quick favor before we start. I regularly receive messages from people who have watched 5 or 6 videos before realizing they weren't subscribed. Could you check right now? It's free, takes 2 seconds, and helps this information reach more people who need it. Now here's why this matters specifically after 60. As we age, blood vessels become less flexible. Inflammation tends to increase. Metabolism changes. Many people develop insulin resistance, high blood pressure, or diabetes. That means the same cholesterol level can carry very different risks in a 40-year-old and a 75-year-old. After 60, context becomes just as important as the number itself. And that's where things get interesting. Because while most people leave their doctor's office with a simple understanding of good cholesterol and bad cholesterol, the reality inside your arteries is far more complex. The story your cholesterol panel tells isn't a single sentence. It's a paragraph. Sometimes it's an entire chapter about your metabolic health, your inflammatory status, your insulin sensitivity, and your true cardiovascular risk. Picture this. You're in your kitchen making breakfast. You feel fine. You walk to the refrigerator, and suddenly there's pressure in your chest. Not severe pain, just pressure. Maybe some sweating. Maybe unusual fatigue. You sit down thinking it'll pass. Maybe it's indigestion. Maybe you slept wrong. Maybe it's stress. Within hours, you're sitting in an emergency department hearing the words nobody wants to hear. You're having a heart attack. Now here's the uncomfortable truth. Many of these patients tell me the same thing. But doctor, my cholesterol was normal. And often they're right. I pull up their records, and sure enough, their total cholesterol from 6 months ago was 195, well within normal limits. Their doctor told them everything looked fine. They left the appointment relieved. They thought they were protected. The myth is simple. Heart attacks happen only to people with very high cholesterol. The reality is different. Heart attacks happen when artery plaques become unstable and rupture. Why that matters is crucial to understand. Cholesterol is part of the story, but it's not the entire story. It's one character in a larger narrative that includes inflammation, blood pressure, blood sugar, genetics, lifestyle, and a dozen other factors working together. Here's the proof. Many people with average cholesterol levels still develop cardiovascular disease. I've seen it hundreds of times. People who thought they were safe because one number looked good, while other warning signs were quietly accumulating. What happens after 60 is that multiple risk factors begin interacting in ways they didn't when you were younger. Blood pressure starts creeping up, blood sugar becomes less stable, inflammation markers rise, weight distribution shifts, often accumulating around the midsection. Physical activity often decreases, sometimes due to joint pain or reduced energy. Sleep quality deteriorates, whether from apnea, insomnia, or frequent nighttime bathroom trips. Medication interactions become more complex as prescription lists grow longer. All of these influence what happens inside your arteries. They change the environment. They affect how cholesterol particles behave, where they deposit, and whether plaques remain stable or become dangerous. Think of it like a house. If you're evaluating fire risk, you wouldn't only look at the stove. You'd also check the wiring, the furnace, the smoke detectors, and the condition of the electrical system. You'd look at whether someone smokes, whether clutter is blocking exits, whether fire extinguishers are accessible. You'd consider the whole picture because fire risk isn't determined by one factor. Your heart works the same way. One number rarely tells the whole story. Here's what your doctor doesn't always have time to explain during a 12-minute appointment while reviewing your medications, discussing your knee pain, and ordering your flu shot. Heart disease is a pattern, not a single laboratory value. It develops over years, influenced by dozens of daily habits and biological processes that either protect your arteries or slowly damage them. So what is the number many specialists pay attention to? For many patients, it's the ratio between triglycerides and HDL cholesterol, along with measurements like non-HDL cholesterol or ApoB when available. Today, let's focus on something most standard blood tests already provide without additional cost or special ordering: triglycerides and HDL. Why? Because these numbers often reveal what's happening beneath the surface in ways that total cholesterol simply cannot. Let me explain. Imagine your bloodstream is a highway. Cholesterol particles are vehicles traveling down that highway. The traditional approach often focuses on how much cargo is being carried, how much total cholesterol, how much LDL cholesterol. These are important questions, but they're not complete questions. But many researchers now recognize that the number of vehicles matters too. Not just what they're carrying, but how many trips they're making. More vehicles mean more opportunities for traffic jams and accidents, more chances for particles to penetrate artery walls and start the plaque-building process. This is one reason measurements such as ApoB have gained attention in recent years. They estimate the number of potentially artery-clogging particles circulating in your blood. Each particle carries a single ApoB protein, so measuring ApoB effectively counts particles rather than simply weighing cholesterol content. For some patients, especially those with metabolic issues, this provides critical information that LDL measurements miss. Now here's where triglycerides and HDL enter the picture. High triglycerides often suggest metabolic problems. They indicate your body isn't processing fats and sugars efficiently. They're frequently elevated in people with insulin resistance, prediabetes, or diabetes. They rise when people consume excess refined carbohydrates or drink too much alcohol. They signal that something in your metabolic machinery isn't working smoothly. Low HDL often suggests the body's cleanup system isn't working as efficiently. HDL particles are sometimes called good cholesterol because they help remove excess cholesterol from arteries and transport it back to the liver for disposal. When HDL is low, that reverse transport system is compromised. Cholesterol accumulates where it shouldn't. When triglycerides rise and HDL falls, it can signal insulin resistance, and this combination creates a particularly dangerous metabolic environment. That's a major concern after age 60 because insulin resistance doesn't just affect blood sugar. It affects inflammation, blood pressure, cholesterol particle size and number, and overall cardiovascular risk. Think of insulin resistance like a rusty lock. The key still works, but not smoothly. Your body has to work harder to achieve the same result. Your pancreas pumps out more insulin trying to overcome resistance. Inflammation increases. Blood vessel function deteriorates. Fat gets stored in dangerous places like around your organs. Over time, this contributes to inflammation, blood vessel damage, and plaque formation throughout your arterial system. A 2021 study published in the Journal of the American Heart Association found that elevated triglyceride-rich lipoproteins were associated with increased cardiovascular risk, even after accounting for traditional cholesterol measures. These particles appear to contribute independently to atherosclerosis development. But here's what actually happens in real clinical practice. Many people spend years focusing only on LDL while missing warning signs hiding in triglycerides and HDL. Their doctor mentions it briefly, but the emphasis remains on LDL and total cholesterol because that's what guidelines have historically emphasized. The conversation stays surface level. Opportunities for early intervention get missed. That doesn't mean LDL doesn't matter. It absolutely does. LDL remains a critical risk factor. Lowering LDL saves lives. The evidence is overwhelming. It means the complete picture matters more. It means understanding how all these numbers work together provides better risk assessment than any single value in isolation. Here's what nobody tells you during that brief annual physical. Your cholesterol panel is a story. Most people only read the headline, but the details matter. The subplots matter. The context reveals things the headline conceals. Now let's discuss practical action. Not miracle cures, not internet myths, not supplements promising to reverse decades of damage in 30 days. Real, evidence-based strategies that actually move the needle when applied consistently over time. First, let's talk about improving insulin sensitivity, because this addresses the root cause of many cholesterol problems in older adults. Picture this: you're eating healthy cereal every morning, low-fat, heart-healthy. At least that's what the box says with its American Heart Association checkmark and whole grain promises. Yet your triglycerides remain elevated year after year. Your HDL stays stubbornly low. Your waistline expands despite eating healthy foods. Why? Because for some people, especially after 60, excess refined carbohydrates affect triglycerides more than dietary fat. The low-fat diet revolution of the 1980s and 90s led many people to replace fat with carbohydrates, often refined ones. Pasta, bread, rice, cereal, snack foods labeled low-fat but loaded with sugar. For metabolically healthy young people, this might be manageable. For insulin-resistant older adults, it's metabolic gasoline on a fire. A study published in The Lancet involving large populations found strong relationships between metabolic health markers and cardiovascular outcomes. The researchers noted that addressing insulin resistance and metabolic syndrome components often improved multiple risk factors simultaneously. Here's the protocol many physicians discuss with patients who need to improve triglycerides and metabolic health. Start by reducing sugary beverages, including juice, sweet tea, regular soda, and energy drinks. These spike blood sugar rapidly without providing satiety. Then limit highly processed snack foods like chips, crackers, cookies, and pastries that combine refined flour with added sugars and unhealthy fats. Next, increase protein and fiber intake at each meal because both slow digestion, stabilize blood sugar, and increase feelings of fullness. Finally, focus meals around vegetables, legumes, fish, and minimally processed foods that your great-grandmother would recognize as actual food. What happens when people make these changes? Within the first week, blood sugar swings often improve. People notice they're not crashing mid-afternoon or craving sweets after dinner. By week 3, energy frequently stabilizes. That 2 p.m. fatigue lessens. Mental clarity improves. After 2 to 3 months of consistency, triglycerides may begin moving in the right direction. Some people see dramatic improvements. Others see modest but meaningful changes. Always discuss major dietary changes with your physician, particularly if you take diabetes medications, because improving insulin sensitivity can affect how those medications work and may require dose adjustments to prevent low blood sugar. Second, let's address physical activity, and specifically why walking deserves more respect than it typically receives. After 30 years, I keep seeing the same pattern. The healthiest 80-year-olds are rarely extreme exercisers. They didn't run marathons. They don't spend 2 hours daily at the gym. They're not doing CrossFit or training for triathlons. They're consistent movers. They walk, they garden, they take stairs when possible, they park farther away. They move throughout the day rather than sitting for hours and then trying to compensate with one intense workout. Walking remains one of the most underrated cardiovascular interventions available, and it's free, requires no equipment, and carries minimal injury risk when done sensibly. Think of exercise like brushing your teeth. Small daily actions outperform occasional heroic efforts. You wouldn't skip brushing for 6 days and then brush for an hour on Sunday. Consistency matters more than intensity for long-term health. A study published in JAMA involving thousands of older adults found that higher daily step counts were associated with lower mortality risk. The benefits appeared to plateau around 7,500 steps for older adults, meaning you don't need to hit 10,000 steps to see meaningful health improvements. Here's a simple protocol that works for most people if they're medically cleared for activity. Start with 10 minutes after meals, which is manageable even for deconditioned individuals. Aim for gradual increases of 500 to 1,000 steps weekly until you reach a sustainable target. Work towards 6,000 to 8,000 daily steps if medically appropriate, understanding that some movement is infinitely better than none. Include strength training 2 times weekly when possible, even if that's bodyweight exercises or light resistance bands, because maintaining muscle mass becomes increasingly important as we age. Now here's where it gets interesting. Walking after meals can help improve glucose control because your muscles absorb glucose from the bloodstream when they contract. This may indirectly support healthier triglyceride levels because better glucose control often means better fat metabolism. Simple, free, powerful, yet most people overlook it while searching for exotic solutions. Third, don't ignore sleep, because this might be the most underestimated cardiovascular risk factor in modern medicine. Here's something most doctors don't explain during office visits. Poor sleep can affect cholesterol metabolism, blood pressure, appetite regulation, and inflammation. Studies show that chronic sleep deprivation is associated with higher triglycerides, lower HDL, increased insulin resistance, elevated blood pressure, and higher levels of inflammatory markers. Picture your body as a factory. During the day, products move through the assembly line. Work gets done. Output happens. At night, maintenance crews repair equipment. They clean machinery. They fix problems. They prepare for the next day. If maintenance never happens, problems accumulate. Equipment breaks down. Efficiency plummets. Eventually, the whole system fails. That's sleep. A study in the European Heart Journal and multiple sleep medicine reviews have linked chronic sleep problems with increased cardiovascular risk. People who consistently sleep fewer than 6 hours nightly show elevated risk for heart attacks, strokes, and cardiovascular death compared to those sleeping 7 to 8 hours. Practical steps include maintaining a consistent bedtime even on weekends because your body's circadian rhythm thrives on predictability. Keep your bedroom dark using blackout curtains or eye masks, since even small amounts of light can disrupt sleep quality. Reduce screen exposure before sleep because blue light suppresses melatonin production and makes falling asleep harder. And discuss possible sleep apnea with your doctor if you snore heavily, wake with headaches, or wake exhausted despite spending 8 hours in bed. Sleep apnea is particularly important after 60 and often goes undiagnosed for years. I've seen patients improve blood pressure, energy, and cardiovascular markers simply by identifying and treating it with CPAP therapy or oral appliances. The improvement can be dramatic because untreated sleep apnea creates repetitive cycles of oxygen deprivation and stress responses throughout the night. Here's what your doctor doesn't have time to explain during a rushed appointment. Sleep is not downtime. It's cardiovascular maintenance. It's when your body repairs damage, regulates hormones, consolidates memories, and restores systems. Skimp on it chronically, and you pay the price in multiple ways. Let's review what the evidence actually says about cholesterol and cardiovascular risk assessment. A landmark study published in the New England Journal of Medicine involving more than 27,000 participants demonstrated that cardiovascular risk depends on far more than total cholesterol alone. Researchers consistently find that multiple markers together predict risk better than isolated measurements. This is why modern risk calculators incorporate age, sex, blood pressure, smoking status, diabetes, and cholesterol numbers rather than relying on cholesterol alone. Another major analysis published in JAMA followed large populations and showed that metabolic health factors, including triglycerides, blood sugar regulation, and blood pressure, significantly influence cardiovascular outcomes. People with metabolic syndrome, which includes elevated triglycerides and low HDL among its criteria, face substantially higher cardiovascular risk than those with isolated cholesterol elevation. Wait until you hear this next part. Research published in Nature Reviews Cardiology has increasingly highlighted the importance of ApoB-containing particles in recent years. This represents a fundamental shift in how many lipid specialists think about cholesterol and risk. In plain English, many experts believe the number of cholesterol-carrying particles may be more informative than cholesterol concentration alone. You can have two people with identical LDL cholesterol levels, but one has many small particles while the other has fewer large particles. The person with more particles reflected by higher ApoB often faces higher risk. A separate study involving thousands of adults found that elevated triglyceride to HDL ratios were associated with increased cardiovascular risk and insulin resistance. Some researchers use this ratio as a simple surrogate marker for insulin resistance and small LDL particle predominance. While not perfect, it's calculated from standard lab tests and provides useful information. The pattern appears repeatedly across different populations, different age groups, and different research methodologies. Not one number, a pattern. And that's exactly what I observed in the emergency department over 3 decades. The patients who did best usually addressed several risk factors at the same time. Not perfectly because perfection isn't realistic or necessary, but consistently, making gradual improvements across multiple areas rather than obsessing over one number while ignoring others. Here's the uncomfortable truth that the supplement industry doesn't want you to understand. Many people spend years searching for a magic supplement while ignoring sleep, movement, blood pressure, and blood sugar. They want a pill to fix problems created by years of habits. They want a shortcut that doesn't require effort or change. The science doesn't support that approach. The body works as a system. Cardiovascular health emerges from the interaction of dozens of factors. You cannot supplement your way out of poor sleep, chronic stress, terrible diet, and complete inactivity. It doesn't work that way. Let's talk about what people get wrong, because avoiding mistakes is often as important as doing the right things. First mistake is obsessing over one number. The myth is that if I fix one cholesterol value, I'm protected. The reality is that heart disease risk involves multiple interacting factors. Why that matters is simple. You can improve one marker while neglecting others and still face substantial risk. I've seen people with excellent LDL who ignored blood pressure and ended up with strokes. Second mistake is stopping medications without medical advice, and this is a big one that genuinely worries me. Some people hear new information about cholesterol and immediately decide to stop statins. They read something online, they watch a video, they decide their doctor doesn't know what they're talking about. Please don't do that. If you're taking cholesterol medication, talk with your physician before making changes. Have an informed discussion. Ask questions. Express concerns. But don't abruptly stop medications that may be preventing heart attacks. For many people, statins significantly reduce cardiovascular risk. The evidence is clear. The benefit is real. The goal is informed discussion, not medication abandonment. Third mistake is assuming symptoms are just aging. You're tired, short of breath, less active. Your chest feels tight when you climb stairs. You can't walk as far as you used to. Many people assume that's normal aging. Sometimes it is. Age brings changes, but sometimes it isn't normal. Sometimes it's warning signs of progressive cardiovascular disease that deserves evaluation and treatment. If symptoms are new, worsening, or accompanied by chest discomfort, dizziness, or reduced exercise tolerance, they deserve evaluation. Don't dismiss them. Don't wait months hoping they'll resolve. Talk to your doctor. I've seen too many people dismiss important warning signs until a major event forced them to pay attention. Fourth mistake is ignoring blood pressure. And here's what guidelines don't always emphasize enough in public discussions. High blood pressure and abnormal cholesterol together create a particularly dangerous combination. Each damages arteries independently. Together, the damage accelerates. Think of it like sandpaper and pressure. Each causes damage. Together, they're worse. Blood pressure monitoring should be as routine as checking cholesterol, especially after 60 when hypertension becomes increasingly common. The research is clear. Total cholesterol tells part of the story, but the cholesterol number that often predicts heart attack risk more accurately is not necessarily total cholesterol alone. Markers such as triglycerides, HDL, non-HDL cholesterol, and ApoB can provide important additional information that changes risk assessment and treatment decisions. This isn't speculation. It's based on decades of cardiovascular research and the real-world patterns physicians observe every day in clinical practice and emergency departments. Here's exactly what to do starting today. Review your complete cholesterol panel, not just total cholesterol. Look at triglycerides. Look at HDL. Calculate your triglyceride to HDL ratio by dividing triglycerides by HDL. Ask your doctor whether additional markers such as ApoB are appropriate for you, especially if you have metabolic syndrome, diabetes, or family history of early heart disease. Improve metabolic health through nutrition, physical activity, and sleep using the strategies we discussed. Keep blood pressure and blood sugar under control because these interact with cholesterol to determine actual cardiovascular risk. Continue prescribed medications unless your physician advises otherwise after informed discussion about risks and benefits. Timeline expectations are important to understand because health improvements take time. In the first few weeks, you may notice better energy and more stable blood sugar as dietary changes take effect. By 2 to 3 months, many people see measurable changes in triglycerides and metabolic markers when they check follow-up labs. After 6 months of consistent habits, cardiovascular risk factors often improve significantly across multiple measures. Important safety reminder: if you experience chest pain, severe shortness of breath, sudden weakness, difficulty speaking, facial drooping, or symptoms suggestive of a heart attack or stroke, seek immediate medical attention. Call emergency services. Don't wait to see if symptoms improve, and always consult your physician before making significant changes to medications, diet, or exercise programs, especially if you have existing health conditions or take multiple medications. The patients I've seen succeed over the years weren't genetically superior. They weren't lucky. They didn't have special advantages or resources unavailable to others. They consistently paid attention to the small things. They walked regularly. They slept adequately. They monitored their health. They asked questions during appointments instead of nodding passively. And they acted before a crisis forced them to act. You have more influence over your cardiovascular future than many people realize. Not complete control, because genetics, luck, and factors beyond our control always play roles, but meaningful influence over multiple risk factors that together determine whether you spend your 70s and 80s active and independent or managing chronic disease and limitations. And that's worth protecting. This video is for educational purposes only. It is not medical advice for your specific situation. Always consult your physician before making changes to medications, diet, exercise routines, or health treatments. If this type of evidence-based analysis is useful to you, please subscribe and like. In the next video, I'm covering one of the most overlooked blood pressure mistakes adults over 70 make every single morning and how to avoid it. And finally, I'd love to hear from you. Comment below and tell me, what was the last cholesterol number your doctor discussed with you? Was it total cholesterol, LDL, HDL, triglycerides, or something else entirely? I read every comment, and your questions help shape what I research next. Until next time, take care of yourself and take care of your heart.